about optimization. We were talking about optimization of ART for pediatric populations. As we all know, this is a population that has been left behind, but with the coming in of dolutegravir, we hope to have better results. So here in the Echo Hub, I'm joined by Dr. Peter Matibula. He's an ID physician and a mentor. I'm also joined by SNAT, a coordinator, Evelyn Mwamba Davis, and we have two doctors from our unit who have worked with us on in the COVID, both outpatient and inpatient, and they've used some of these newer therapeutics we'll be talking about. Our expert for today is Professor Lloyd Mulenga, who will be sharing his screen. Professor, you are welcome. I saw your screen. May you please share it again? It's perfect. Okay.
Dr. Foloshi and team, good afternoon. Are you able to see the screen?
Yes, Professor, we're able to see your screen.
Thank you. You signal me when you are ready.
We are ready for you, Prof. You can go ahead and start.
Thank you so much, colleagues. We are living in difficult times, and I was asked to share a few things on SARS-CoV-2, the variants, and also the projections we have for the fourth wave. Before I go into that, allow me to thank Dr. Foloshi for the great work that she's been doing with all of you in moving forward this agenda of reminding one another of how best we need to care for various clients or patients that we have. And even as we prepare for a possible fourth wave, we are looking forward to again working with you on trying to minimize the impact of COVID-19. Also allow me to welcome Peter and also SNAT who will be joining the team. We welcome you, and we hope that you'll fit in smoothly and will be able to even reach greater heights. Colleagues, when it comes to COVID, this is something which has been challenging for the country, but also for the globe. We'll just briefly look at where we are globally, and we'll concentrate on the situation here locally, and also how ready are we for the fourth wave? What is it that we need to do? And also we'll look at the vaccination status and also the targets. And we'll lastly look at the new available medications that we have brought on board on the treatment and care aspect of COVID-19. We are still fighting this pandemic with now more than 265 million total cases cumulatively. And we have seen for the past 1 month an increase of almost 15 million cases. And we have more than 5 million deaths. And we have, of course, the vaccination above 8 million. Although when you look at the areas where the vaccination is, we've been disproportionately affected in terms of coverage. Again, when you look at the cases, you see those in red, Europe is having a high number of cases, the Americas as well. The USA, the cases are also rising. In Africa, where you see those dots, again, what is concerning here is South Africa as an area which can lead to the region being affected as well. When we come to our situation here, we have seen just some slight increase in the number of cases the past 2 weeks to 3 weeks, just a slight rise, especially the last week. And this has coincided as well with the news which we have over the new variant, the Omicron variant. When we look at the past 24 hours, again, the number of cases that we have recorded, confirmed cases, are just 15. And we also had 1 death, unfortunately, in Muchinga, a male, 87, and vaccinated with no comorbidities with severe COVID infection, the severe COVID pneumonia. That is where we are. And in terms of vaccination as well, we are slightly under 800,000 for those that are fully vaccinated. So we have the poll number 1. Dr. Follosh, are you able to lead us through this?
Okay, so we'll go ahead and read the first poll. So this is a true or false question. So you indicate whether it's true or false that virus mutations always have consequences which may either be positive or negative. I'll read the question again as I launch the poll. True or false, virus mutations always have consequences which may either be positive or negative. You can see some responses coming in. Okay, we'll just give it a few more seconds. I think the participation has been almost 100%. Yeah, so true or false, virus mutations always have consequences which may either be positive or negative. All right, so I'll end the poll now. I think we've had about 247 responses, which is quite good. Okay, so end the poll now. And share the results. So I don't know if Prof, you're able to see the responses, if it reflects what is obtaining, or we'll see from the didactic presentation if learning will have taken place. I'll hand over again to Prof to proceed with the presentation.
Thank you for that response. I'm encouraged by the way the number of overall participants is quite good, but also the response as well, where we have 257 responding. We really, again, get encouraged when people are majority are thinking towards what is right. Yes, so when you have a variant, that variant just means there's a difference from the mother virus in this case, and the consequences may either be positive or negative. We'll see some mutations which happen, they lead to a particular virus not being highly infectious or highly transmissible as well. It may become weak, but some may also lead to it being transmitted faster and also being more virulent. So it can have negative or positive consequences. Thank you. So the mutations really are just the changes which happen on the genome. And once those mutations, some may have no consequences, as we said, then some may have a negative impact on the viral behavior. And the ones which we are concerned about increased transmission, increased severity of disease, but also escape immune responses, where including the vaccines, where the vaccines may not work, but also even the natural immunity as well, not being effective. Then you can have the therapeutics, the drugs which we use, not working well because of these changes which do happen, the mutations. And at times, you can have diagnostics not available as well to pick a particular virus or mutation or a variant. We have seen in certain viruses, including COVID as well, the fears of establishing the SARS-CoV-2 in an animal reservoir. And these may really be related to the mutations as well. So the important things here, which we are concerned about, are increased transmission, increased disease severity, but also the vaccine response being reduced, and the diagnostics as well. These are the major ones which we worry about. Let me just briefly highlight the variants which we have and how the mutations do happen. These happen in the area of the genome, although what we see, the actual effect we see on the protein itself. And the main effects which we can see are increased transmissibility and also antibody or vaccine escape. This is again what was referred to, and pathogenicity, where you have an increase in the number of severe cases. Now, the ability for the virus to be easily transmitted is determined by the changes which happen on a certain portion of the genome, which is called the receptor binding domain. If you can see here, the one marked X here, those are the various the various codons. Now, codons are just specific areas where you have the bases combined with other molecules, the phosphates and also the glucose. When you have the three of them, one codon would code for one amino acid. So now the area where the antibodies bind and also even some of the therapeutics bind, that is the spike protein. And on this spike protein, there's a specific region which is called the receptor binding domain. And if you have mutations around there, then you are likely going to have antibody and also vaccine escape, where these are not going to work well. Again, this is looking at it now from the structural point of view. And when you look at this dimension, you can see that this is the virus, the SARS-CoV-2. And on this SARS-CoV-2, we said we have a spike protein. That's the region which we saw there. And on this spike protein, we have the receptor binding domain. Now, this receptor binding domain, this is where you have also binding of the virus to the AC2 receptors, which are in the lungs, the kidneys, the intestines. This receptor binding domain is the one where the antibodies do bind as well. And if you have any mutations on this binding site, then you're going to have the antibodies, vaccines, even some drugs, depending on which type of mutations happening on this receptor binding site. You may have escape, where they won't be able to block the virus from entering the alveolar cells and other cells, depending on the region which is affected. And as a result, what you're going to have is infection going on unchecked or without any inhibition. Going back again, we had shared this before, if I remember well. WHO has classified these variants into three. You have the variants of interest, where you have the mutations, and there may be some community transmission in multiple cases as well. But these variants of interest, they do not have any global significance like the variants of concern, which spread to many regions across the globe. And also they may be associated with the three things which we highlighted: transmissibility, severity, and also reduced effectiveness of vaccine therapeutics, and also the diagnostics. These are the variants of concern. We also have the variants of high consequences. These variants of high consequences, we have none picked so far. If you have this variant of high consequence, you would not be able to pick the virus from the diagnostics which we have available. Then also you may have the drugs not working as well. And if that is the case, you are going to have severe clinical disease with increased hospitalization, yet you are unable to pick this particular variant. So these are the three classifications for the variants. Now, briefly on the nomenclature, we were using this nomenclature before, where you classified for the SARS-CoV-2 the variants that are first circulated. You have the A or B, defining which region they may have emerged from. Like B1 includes an outbreak which was in Europe, and if it's 351, it means it's a descendant from that lineage. And this is just a tree visualizing the circulating lineages as well. So you see there are different mutations which do happen, and you can at least try and see to which line they do belong. We now have the classification and naming introduced by WHO using the Greek alphabet. And here you can see alpha. From the Greek alphabet, you can see beta, gamma, delta, and also the Omicron as well. This has made it easier and also reduced the issues of stigma opposed to what we're using before, where you call a certain variant based on the country where it was first isolated. From the five big ones, we know the Delta especially has increased transmissibility and also disease severity possibly, and where you may have certain drugs not working. But for the monoclonal antibodies, it's the Beta where you have reduced effect, and also the Gamma, you have reduced effect for the monoclonal antibodies. The Omicron, there will be a short detailed discussion on the Omicron, a short discussion on the Omicron variant in the slides to come to see if we have data showing any of those impacts on transmission, severity, and also immunity and the diagnostics. Again, this is just what was highlighted, where you may have the antibodies not working, again, depending on the mutations which are on a different, or on the receptor binding domain, which is part of the spike protein. And we'll highlight also briefly on the Omicron variant, where we have those specific changes. Now, this is just again a slide showing on the monoclonal antibodies against the variants of concern. And really, it's the Beta and the Gamma for the monoclonal antibodies, which we'll discuss later on, the Bamlanevumab and also the Receptor, where they've reduced effectiveness for these two. Delta does work, Alpha, Epsilon, and other variants are able to respond to these monoclonal antibodies. Now, this is looking at the variants which we have had in Africa, and largely you can see an increase which we have had for the Beta, and also the one in light blue, and also the purple one, that is for the Delta, which was the majority of the variants which we saw in the third wave as well. We've also have, of course, other variants which are circulating in the and also the continent. Again, this shows the various variants. You can see the Beta and also the Delta in certain regions, like in Southern Africa, South Africa, Botswana there, Zambia as well, where the Delta was ravaging many countries. And this is true as well for Europe now, and also the Americas. Peter.
All right, thank you, Prof. For that, we'll now move on to poll number 2. Okay, so I'll read the poll question. So regarding COVID-19 vaccination in Zambia, which of the following, which of these is true? A, more than 10% of eligible people in Zambia were vaccinated by end of September. B, the vaccination target for Zambia by December is 30%. C, more females than males have been vaccinated. And D, preliminary data from Zambia have not shown effectiveness of vaccines. Okay, so we can see some responses coming in. As people respond, I'll go through the poll question again. Regarding COVID-19 vaccination in Zambia, which of these is true? A, more than 10% of eligible people in Zambia were vaccinated by end of September. The vaccination target for Zambia by December is 30%, that's B. And then C, more females than males have been vaccinated. And D, preliminary data from Zambia have not shown effectiveness of vaccines. Right, so far we have over 200 people who have responded. We are still waiting for someone from Chipata to respond. Then we can end the poll in a few seconds from now. We have a considerable amount of people who've actually responded. About 19% so far for A, 50% for B, 27% for C, and 13% for D. I think I'll now end the poll and share the results. Prof, you can see the responses. We'll see with the as the discussion goes on, maybe people will have a change of heart after the discussion. Thank you. I'll hand over to Prof. Probably you can discuss briefly on the poll results.
Thank you, Dr. Matibula. And again, good to see a variety of responses. We really set ourselves having a target of 30% of the vaccination by end of this month. In fact, our main target is to have by Christmas 2 million extra doses given to individuals, and that is the true answer. We have seen a reduction, a less number of females compared to the males, those that are accessing vaccinations. And we hope that we can increase this. Right now, we just are slightly under 10%, 9.8% of individuals are fully vaccinated. We need to ramp up the vaccination. And as we do so, we need also to engage each one of you to take this very, very seriously and also educate the masses out there. If we are not vaccinated, let's get vaccinated. Then this is where we are with the vaccination. This is as of, we end this. So we have still a long way to go. And this, of course, has reduced currently. We have 9 in admission, but in terms of the vaccination, still under fully vaccinated, under 800,000. We hope that with also addition of the Pfizer, which we are starting to give this week, possibly today, certain centers have started, like UTH and many other areas in Lusaka, then we are going to have another set of vaccine introduced in the country. So the vaccines, we know they induce immunity, and once they induce the immunity, then once we're exposed to the disease, then there's a protection to that disease. And we have different types of vaccines, the killed live, and also viral protein, and also viral vectors and messenger RNA. Currently in Zambia, what we have are the viral vectors and also the messenger RNA as well. We have a number of cases which have been averted because of the vaccines being available and the vaccination as well given to individuals. When we look at the platform of the vaccines which we have, we see that the Janssen, which is the J&J, and AstraZeneca are among the top. In fact, we have now more coverage of the J&J or the Janssen vaccine, and with the efficacy of 67% in clinical trials for the Janssen, and also 82% for the AstraZeneca. The Pfizer 94%, then the Sinopharm about 78%, with again very rare side effects which have been recorded from these vaccines. There are more than 30 viral effectiveness studies, and we are also doing one here in Zambia. And really, we've seen that one dose does give protection up to 60 to 70%. The minimum I've seen in certain studies is 30% for the first dose. Then 2 doses will go up to 80 to 90%. And this is in the real world, outside the trials. And data is largely around Pfizer and AstraZeneca because they've been these have been administered widely. And we also know very well that there can be breakthrough infections for individuals that are vaccinated. And however, if someone is vaccinated and they have a breakthrough infection, the rate of transmission is also reduced as well, 50% less likely to transmit to household members just because of the vaccines. And that's why we need to have the vaccines available. This is looking at the vaccine effectiveness against the variants of concern. You can see that for the Delta, there was some reduction with 37% on dose 1 and 30%. I referred to this earlier for the Delta. Then as for dose 2, 64 to 88% for Pfizer and AstraZeneca, up to 7%. Very, very rich data, and also encouraging data that there's some really protection which is given, which is gotten from the vaccines as well. And this is looking at the breakthrough infections. These are when someone becomes infected, the breakthrough infection, when someone becomes infected after they've been fully vaccinated. And this is something we need to emphasize, colleagues. It's expected. There's no vaccine which is 100% effective. And we know that Delta may likely lead to breakthrough infections. I also need to say that this is true as well for the Omicron. I hope I'll remember this point when we come to discussing the Omicron variant. But importantly as well, there is very, very low severity among the vaccinated persons. We have our own data here as well, where we've seen that if someone is admitted or hospitalized in our facilities and they are vaccinated, when you compare the chance for, or the risk of them dying compared to those who are not vaccinated, the ones who are not vaccinated have 26 times higher chance of dying compared to the vaccinated. And that message should resonate within us and also to the population out there, showing that the vaccines do work. They protect against severe disease, and they do against transmission, and protect also against mortality. Emphasizing again that there is no vaccine that is 100% efficacious. And with the titers of the antibodies, they also do lower after some months of being vaccinated. And there is a trial which is going on here being led by CIDers as well, looking at how high do the titers or the antibody levels go after being vaccinated to various vaccines, and when do they reach the lowest levels, trying to inform us if we can give the booster doses and at what level can we put these booster doses. But we need to emphasize masking, physical distancing, hand washing, etiquette around respiratory and also the cough hygiene, avoiding the crowded places, and also good ventilation. These are important practices which we need to continue and maintain even after we've been vaccinated. So really, these are the vaccines which we have, and we need to get vaccinated. Either use AstraZeneca, Janssen, Sinopharm, or Pfizer. They are very, very good vaccines which we have. Let me now go into the discussion on the Omicron variant. Now, this was first discovered in South Africa, a high number of mutations which are concerning. Then there are reports as well from Botswana, Hong Kong. We have also detected this specific variant as well in our country. So far, even what we have seen is that we are able to pick from our diagnostics, we are able to pick these variants here. So there's no escape from the diagnostics, which is really, really encouraging. However, the spread has been really fast. Even right now, when you look at the cases that we have, we are still following up a number of contacts, and some have been turning out to be positive a week after the contact. So really, there's increased transmission, and this may lead to the beginning of the fourth wave, or this may be what really makes the fourth wave even more of a reality now. It's the presence of this new variant, the Omicron variant. Again, these are the changes we said of the Pango lineage. We said the B, the ancestral viral pattern discovered in Europe. And we have now from that lineage the 529. So the mutations are from there, from that lineage. And when you look at the substitutions, which I'll highlight, now don't worry, we have a deletion, but we also have substitutions as well. And this was first identified in South Africa. It doesn't mean that it originated in South Africa. South Africa was just the first country to have diagnosed it. We have data as well showing that there is potential for increased transmission, but also that the monoclonal antibodies may be reduced. We haven't seen that so far, but maybe there's potential as well for reduction in vaccine efficacy as well. Now, these are just potential, but increased transmissibility, there's almost an agreement that when you compare the Omicron variant to the Delta variant, the transmission is 2 times faster with the Omicron compared to Delta. And again, I come to this picture looking at the genome of the SARS-CoV-2, and now this is for the Omicron variant. When you look at this, remember I said that the spike protein, which is this one in green, you can see here, you may not appreciate this, but the green pattern there, that is the spike protein. Now, and on this spike protein, there is the receptor binding domain. Now, on this receptor binding domain, that's where you have an increase in the number of mutations. Now, again, on this receptor binding domain, there's a certain area which is called the receptor binding motif. So on this motif, let me just highlight the importance of these changes. There, in the Delta wave, the Delta variant associated with the third wave here, there were differences of 2 rather, to the wild virus or variant, so to say. And when you look at the data on this Motif, there were 2 changes. Now on this one, on this Omicron variant, the changes are 10. And when you look at the overall receptor binding domain and the spike protein, there are more than 30 mutations. In fact, 32 mutations. Now, those are 32 changes from the wild or the original virus, which is really, really concerning. And it's this which has led to many, many people panicking, not looking at how this has affected the behavior of the virus. The panic really has been because of this number of mutations. Overall, when you look at the whole genome, more than 50 mutations observed on this genome, which is really so far the highest in terms of mutations. And we don't know if really this is going to affect the immune evasion. So far, there's indication that immune evasion is there. If someone had been infected with COVID before, they can still get this Omicron variant. So that is concerning. But also, if someone is vaccinated, we know that they can still get this Omicron variant. And this data we have even from the individuals that have been diagnosed here. Again, when this slide is just looking at the early ones, like in Gauteng in South Africa, you can see that for the 77 samples in Gauteng, which is the Pretoria, Johannesburg area, 100% of those, they had the Omicron variant. For KwaZulu-Natal, where we have Durban there, it's about 20%. About 20% for the KwaZulu-Natal. Again, showing a rapid increase. You look at this line is just so sharp within a few days, showing that there's a rapid rise in the number of cases as well. And again, if you look at the rise, this is showing it very, very clearly. But what is also encouraging is that just with our PCR assay, we are able to detect this. And also when they do the genome sequencing, just with one particular assay, before the whole genome sequencing. So before you even analyze the whole genome, there are areas which are looked at and you'll be able to share that this is likely to be the Omicron variant or the B11 variant also recorded in here. We have seen this as well similarly. I'm sure some of you may have attended the press brief which happened on Saturday. And we were with the people that isolated this variant from our lab here in Zambia. And they were able also, when you talk to them, that just with, before you analyze the whole genome, you'll be able to show that these mutations B11529 related. And again, that gives us an indication that this is a variant which can easily be detected with our mechanisms which we have in place. We have 3 cases detected so far from the Unzavet lab. 2 of the 3 at recent travel, international travel. What I need to mention is that we had 16 samples that we sent for genotyping. And of those 16, only 3 are the ones which were amplified. The others, the viral load was low. That's why what you call these the CT values, they were high. They were above 28. Because they were above 28, they could not be amplified. And interesting, 2 of these are vaccinated and have mild symptoms. Then 2 of them, the ones who are vaccinated who had international travel, even their partners or wives, they also tested positive for SARS-CoV-2. But the viral load was low, so they could not be amplified. So we can safely assume that there are a number of individuals right now who have the Omicron variant, but because the viral load is very low, we cannot confirm that this is the Omicron variant. It's likely that the two couples we are talking of, even the spouses who are SARS-CoV-2, but we don't have data to prove that it's the Omicron variant. It's safe to assume that they also have the Omicron variant. Just this afternoon, received more information through the contact tracing that there are more people again that are testing positive who have been the contacts to these three cases. What is known is we know what the genetics is showing us, but what is the phenotypic impact? We don't know really over the vaccine escape. We don't know over the disease severity. We don't know the risk of reinfection, but data is indicating that reinfection may happen. We know that transmissibility is high, likely 2 times higher. And also we know that the diagnostics which we have are able to pick this variant. And when we say, do we have a resurgence in the cases? If we have 20% and above in the increased new cases, after a period of being calm, like this, the way we have had a period of lower or no transmission, for us now, it's been more than two months, we can say. So if we see a resurgence where we have 20% above increase, then we start getting worried that we're having the new cases. As at now, we have less than 10% increase in the new cases. So we are saying that now we are under control. When we see 10 to 20% increase in the new confirmed cases, that would be an alert. So even as we discuss possibilities of the fourth wave, we still have the pandemic under control, but we are going to levels where we may still having an alert. And again, if we go more than 20%, then there will be a resurgence, and we're going to start now thinking of when do we call a fourth wave as being in. There are various models that we use to predict a wave, but certain principles that we may just need to know is that we know that the weather has a pattern here. We know that the rain and cold seasons, they have been associated with the major waves in this country and also the region as well. But also related to that is the variants which were there. We know that the first wave coincided with the wild virus from Wuhan. That was the first wave, but also it happened during the month of June into September. So it was cold, windy, that was favorable. And also we had very low immunity. The Beta variant, which came in the second wave, coincided with the cooler times when it was rainy and also cool. That was from December into February, March. As well, that was a time after we had been calm from September to November. There was a period of calmness and the population lost that overall immunity which they had from the first wave. The third wave, similarly, if you look at third wave, which started again in June, so the weather was very conducive, but also from March to June, we had about 3 months of being calm. So again, we lost the immunity to the SARS-CoV-2. And so when the new variant came in, it found a population which had lost immunity. In the same principle can be applied to the fourth wave. We are now at a time where the general population is losing immunity. Possibly now almost many people who are not vaccinated have lost that natural immunity because of the exposure they had due to the Delta wave in the third wave, the Delta variant in the third wave. Now we have a new variant, the Omicron variant, which is spreading fast. Then we are also getting into the rain season, cool season. So again, we have conditions which are being met for a fourth wave. Other things that we also need to look at, especially over the severity of the wave, is to look at how many have been exposed. So for now, we can see that the exposure is very, very low. How many have been fully vaccinated in a model have to be put in as well. And we need to look at the mitigation measures which have been put in place as well. And this is what I was saying over the various variants and also the waves. And this is true for South Africa and also for Zambia. The one on top here is our country, Zambia, where you can see the first wave was associated with a natural variant, the original variant from Wuhan, and the second wave was associated again to the Beta variant. This is the green one. And similar again in South Africa, you see this was coinciding with the second spike there. Then the third spike was associated in our country with the Delta variant, and also similarly with the Delta variant in South Africa. Now, South Africa has already started now seeing an increase, signaling for them a fourth wave. And it's just a matter of weeks before we are also affected wave coming in, because we have met those conditions. So there is what is called the COVID-19 scenarios as well, which just helps in determining how we are going to be hardly hit. So it looks at the outbreak, how the outbreak in a certain community is affected by the certain measures which have been put in place, the restrictive measures and also effective control measures. Things like screening of international travels at arrivals, isolation of confirmed positives, restrictions, travel restrictions, business restrictions, wearing masks. So all these have an impact on how the disease can be transmitted within the community. So when you want to predict how severe a wave is going to be, you have to look at all these various factors. Are they in place in a certain country? Then that helps you in your model. Although these models, I need to emphasize that the models are not perfect, but they really do help us in terms of planning. It's better information which we get from there, though not perfect. Thank you so much, Dr. Fellowship. Before we go into the next slide, can we have maybe a discussion or even some questions? Because we now look just at the therapeutics, we're moving away from the variants and also the vaccines.
Thank you so much. Thank you so much, Professor. I will allow you to take a breather before we have this brief discussion. I know Katauka Mufelo has raised their hands, but I'll allow Dr. Peter to ask his question. And just sincere apologies. We created the new variant they are called Upsilon. That was meant to be Omicron. We'll correct that before we send out the slides this moment.
Okay, thank you, Dr. Foloshi. Probably just a comment. We do remember somewhere around September in South Africa, there was a talk about the C.1.2. And then now there is Omicron. What happened to the C.1.2?
Thank you, Doctor. So the C.1.1.2 really was something which we thought the spread may be faster. Right now, it's one of the minority. In fact, it's even not high compared to the Delta. So when you look at South Africa, you have still majority of the cases that are there. It's the Delta. Then now followed the Omicron is following, and it's still the Omicron, even though it's lagging behind the Delta variant, it may overtake the Delta variant soon. The C.1.2 has not really been a dominant one. It was really feared, but the increased transmissibility is not a factor with that. And initially we had thought that this is the variant which is going to lead to the waves in our region. Unfortunately, it's one of those where even despite having the mutations are not that detrimental for them to lead to increased spread in the community and leading to a wave.
Thank you for that response, Prof. I'll go ahead and look at other questions that were asked. I think we had Katauka Mufelo who raised the hand. Katauka, can you go ahead and ask your question, please?
Yes, good afternoon, Doc.
Good afternoon.
Good afternoon.
Hello. Yes, please. Yes, it's probably it has been explained because I wanted to get confused on the Omicron that I was seeing to say, is there a new variant also far that has also been detected here? So it has been explained to say it's just a typing error that was, meant on Omicron instead of Omicron.
All right, I think we had another hand from Bekilize Mushanga. Could you go ahead and ask your question?
Thank you very much, Professor, for the well-elaborated presentation, and moderator. To get clarification, or maybe to understand, one, I hope that now, currently, where our vaccination status stands percentage-wise, it was interesting to note that we have fewer women or females who are vaccinated compared to males. I don't know if now with the new policies from the Ministry of Health, the guidance and the direction that has been given, whether they are direct policies intended to increase on the vaccine uptake across the country. Yes, I think I'll hold there. Thank you.
All right, so Prof, were you able to get the question, or maybe Dr. Mshanga could repeat the question? There was a bit of background noise.
I think maybe I may have heard that it was more of a comment rather, that possibly with the new measures, we are going to increase the coverage for vaccine. I thought it was in line with that. And also it was concerned about the fact that we have less female compared to the male who are vaccinated. This has been really the trend we have seen from the beginning, and especially, there were a lot of issues around pregnancy, around breastfeeding as well. So the uptake was really, really low. Even though we have lower numbers now, there's just a difference of about 2% between the male and the female. So they've slowly trying to catch up, but still, this is a battle where, at least for now, we can say that the men are trying to be at least out there to be noticed as people in the lead. But we hope that more women can come on board so that we can have a fully vaccinated community.
Okay, thank you. Thank you, Prof, for that response. I think we'll proceed and look at the hands that were raised. There was another hand raised from Geoffrey. Geoffrey, could you unmute yourself and ask your question, please?
In fact, I'm just being corrected now. Thank you, Dr. Bobo, that for now, for the latest, we have the females have overtaken the males slightly in the last few days. And this is encouraging, Dr. Bobo, and thanks for that correction. So now we have men again, we are beaten. So it's encouraging to see that the women are really now leading, with a percentage of the male having 49.5% and the female 50.5%. So encouraging. Thank you, Dr. Bobo. Are you connected, Dr. Bobo? Maybe you can highlight that and any other highlights on the vaccines. Is Dr. Bobo? Okay, when she comes in,
Dr. Bobo
Yes,
is one of, yes. Please go ahead.
Yes, Professor, I think what you've said is actually true. We've seen in the past few weeks, at some points, I think it was almost 50-50, but like you rightly said, as of a few days ago, females have actually overtaken the males. And yeah, I think basically that is where we are. And I think that is the reason why I said question 2 had 2 right answers. I don't know if people saw that. Over to you, Professor.
Thank you so much, Dr. Bobo, that we didn't realize that that had happened, because Prof was saying that Dr. Foloshi, the women always do better, but in vaccines we are beating you. But Professor, that has changed. Thank you so much, Dr. Bobo, for being on our panel.
Okay, so I think we'll look at some questions in the chat. There's a very hot question from Dr. Edwin Musonda. What's the current guidance on booster with regard to vaccines?
Very topical, and I'm glad we have the panel here, which are going to help in answering that. So far, it's not policy for. We don't have policy so far for the boosters. We, of course, are considering some technical input into that before policy can be arrived at. As you know, we have a lot of priorities. We have a lot of people that are not vaccinated. If we can maximize on vaccinating those that are unvaccinated, then we can have a larger rise in the number of people that are contributing to that overall immunity we need for the population. And of course, personally, I think there is great room for certain populations to receive the booster doses. But once that policy is made, then the country is going to be informed. Dr. Bobo and team, are there any other additions to that?
Thank you very much, Prof. And as you have rightly said, as at now, we are not giving any boosters. And the reason is basically what you've said, but also we have to bear in mind where we're getting most of our vaccines from. Right now, the COVAX mechanism through the WHO is also not in favor of boosters, especially for countries like ours, whose vaccination coverage is very, very low. So like what Prof said, they would rather we actually reach more people with the initial vaccines before we actually start talking about boosters, as well as for those who are not maybe, who are low risk, so to say. That's my response. Thank you.
Okay.
Thank you, Dr.
Thank you
Bobo.
very much, Dr. Bobo. So I think we'll allow further some hands. I think there are 3 hands so far. We'll start with Dr. Shivemba. We'll allow a comment from Dr. Shivemba, then Mr. Patrick Makelele, and then Manfred. So we'll start with Dr. Shivemba. You can unmute and give your comment.
Yeah, thank you very much, and good afternoon, everyone. I also totally agree with Professor and Dr. Bobo's contribution on the booster. But as you know from basic sciences, that when you have a vaccine, some of the vaccines takes a specific period of time when the immunity starts going down. And it's at that time that you give a booster dose. So again, the science is still ongoing with COVID-19, and some have found that there's need for a booster, and that booster can only come after a certain percentage of the eligible population is vaccinated. Over.
Thank you, Dr. Shivemba, for the comment. Can allow Mr. Patrick Makere. Can go ahead with the question or comment.
Makelele, thank you. Yeah, it was a comment actually. It was previous to this one. I wanted to comment. From Katete district, we observed this earlier and we worked hard. A misconception which came with it and the lack of evidence. But I would like also done in terms of IEC to convey the message.
But then you move to you're sharing the data.
Repackage the message accurate way to our fellow women.
Okay, Mr. Patrick Markere, I think your internet is quite poor. We're unable to get what you're saying.
Okay.
You can type in the chat box and we'll be able to look at the comment.
I
Thank
will.
you. Okay, all right, thank you. So the other hand was Manfred. You can go ahead with your comment or question. You can unmute yourself.
Yes, good afternoon, Prof. My concern is basically on the uptake of the vaccines at my facility where I am. Basically, we are doing a 24 hours coverage for vaccines. So the problem here we are facing is that clients are shunning away. Once they know that there is no JJ, they are opting out. So they are only preferring Johnson & Johnson than the others. So my fear is we're going to have these others actually are not accepting to get them. So their preference is just JJ. So I don't know what we are going to do, but we are trying as much as we can in terms of canceling them on the other vaccines that we have.
So for you guys, they wanted to talk.
So I think this is my concern in terms of expiring with the others that are not being taken by the clients.
Again, thank you for that. The panelists, Dr. Bobo, Dr. Shibemba, I think that's a concern. Dr. Bobo, where are we with the receiving of the J&Js to have the good stock of J&J?
So thank you very much again, Prof. I must add that Zambia is one of the very few countries in the region that went for this, the so-called basket of vaccines. We have a variety to choose from. Other countries actually, from the beginning, only opted for 1 or 2 vaccines. So now we find ourselves in a situation whereby people are actually, free to choose what they want, the vaccine that they want to get. But having said that, we are also mindful of the fact that the vaccines that we have are not enough to go around. So in this case, when you talk about Johnson & Johnson, we have limited stocks and we have other vaccines as well. So of course, we know that it is easier in many circumstances to administer Johnson & Johnson. Even I think the healthcare workers prefer that because then they know they don't have to go back to certain areas to go and vaccinate again. And also, I think some of our people are actually advocating for Johnson & Johnson. But that's having found ourselves in this particular situation, we don't want any vaccines to expire. And I think it's going to be criminal. We all know that so far, Ministry of Health is trying to rebuild its reputation. And we don't want a situation whereby we're going to start having a lot of vaccines expire. So our plea to all of us is that at the end of the day, the vaccines, like Professor did try to show, all have some protective, aspect of it. They are all protective. And that is the language that we want to actually start, giving out. Of course, there will be those people who would actually say, I just want that particular vaccine. But remember, we are fighting the 4th wave, the possible 4th wave. We have this common enemy. So we want to try to start moving away from this issue of saying Pfizer, J&J, AstraZeneca. We want to be calling them COVID-19 vaccines because that is what they are. And we'd want to reach a point whereby as healthcare workers, as providers, we try as much as possible to actually sell these products because we are getting them at a very high expense and really we wouldn't want any of them to expire. I think that should be my plea. So we understand that, but please try, help us to make sure that whatever that, is available is used. I think that is what I'll add. And maybe just before I conclude, I just want to say that, J&J, we're trying to reserve them for certain areas, very hard to reach areas. We know of places that get cut off in the rainy season, for example. And we know that it might be very difficult to go back and vaccinate people and we give them the second dose. So in those areas, it makes sense. But if somebody can come back for a second dose, please we should work together to make sure that they do that. Thank you, and over.
Okay, thank you, Dr. Bobo, for that response. In the interest of time, I think we'll allow one more question from St. Francis. The hand was raised. So St. Francis, you can unmute yourself and go ahead and ask the question. Over to St. Francis.
Yes. Good afternoon.
Afternoon.
Oh, yes. This is Dr. Banda from St. Francis. So I was following very stimulating presentation, Prof. and the team. The question that Dr. Shwemba raised is very important. There are issues there. For example, for us to know whether the immunity is still has went off, we need to carry out tests on the people that have received the vaccine. So maybe my question would be, is there anything in the background that is going on to assess, for example, someone has received J&J or AstraZeneca, and then we say, from the point of administration of the vaccine, what is the level of immunity at this point? At which point we need a booster? We know that logistics may not allow for a booster, but from the scientific point of view, where would we say safely the population is safe? The worry is we reach a herd immunity when some of the people that have been vaccinated, their immunity has actually gone down in terms of the titers for the protection. So maybe a response on that, what exactly are we supposed to do as a country? Looking at the response from the people is quite slow in getting themselves vaccinated. How far is this immunity going before someone is eligible logistically to get a booster, even if the circumstances may not allow? Thank you.
Thank you, Doctor. Indeed, you raised a very important point, and that borders on the research. We have two studies which are really looking at that here in Zambia. We looking one at the levels of immunity and the protection which is conferred by different vaccines over time. We are also looking at the various people that have breakthrough infections and have been vaccinated, looking at the severity of disease, the length of hospital stay as well, including the time to development of severe disease and also critical disease as well. When we have that information, then we'll be able to come up with local data which may inform guidelines as well. As of now, we have no really answer from the research locally generated here, and we are relying on these two trials to better inform policy. My fellow Dr. Shwemba, Dr. Bobo, is there any contribution to that?
No, I think you've adequately answered it. I think we are waiting for guidance on that. We know for sure that some countries have actually started giving boosters, but we always want to, get also, scientific guidance, but also we shouldn't forget the fact that even political leadership also have a say in this. And like I mentioned, I did mention WHO. Those are the ones who are giving us most of the vaccines that we have so far. They also have a say. So it's a lot of things that we have to consider. But I believe that policy is not rigid, and it is bound to change according to the evidence and where we find ourselves. Thank you. Over.
Okay, thank you. I think in the interest of time, we'll move on, but briefly before we move on, I'll ask a comment from one of our experts on the call, Dr. Shivemba. Any comment on genomic sequencing currently in the country?
As Dr. Shivemba dropped out? If he has, maybe I can pick it up, Doctor.
Okay, you can pick it up, Prof. Thank you.
Yeah, so colleagues, for now, we are encouraging those that do test positive SARS-CoV-2 either by antigen or PCR-based testing to be sent for genomic sequencing. We have the UNZA Vet Lab doing genomic sequencing. We have the Public Health Lab, the Zambia National Public Health Institute lab, which is based at the Levi Mwanawasa Medical University Lab, also doing genomic sequencing. We also have TDRC on the Copper Belt. We have MACHA as well. And we are about to also start in UTH. So we have these major platforms, including CHAS, where we can do the genomic sequencing as well. When we are overwhelmed with the number of samples which are coming in, and after we have a good understanding of which ones may be the predominant pattern of the variants we have in the country, then we'll be able to just analyze samples, and directives will be given. Maybe the 10th sample, you pick it, and also sample from outpatients and inpatients and send it over to those labs. Thank you.
Okay, thank you, Prof, for that. I think in the interest of time, we can proceed with therapeutics for COVID-19 available in Zambia. I know there's been a lot of questions regarding booster, but due to time, probably we can arrange another session just to discuss vaccines and booster, and also any updates on vaccines in children. You can go ahead, Prof.
Thank you. Let me just, before going there was a question on why was the viral load in people infected with Omicron low. As you know, it depends on how someone was infected, the initial inoculum as well, how high it was, and that duration has a part to play. So yes, even though we believe that there may be Omicron, but again, we don't know how long it takes for the levels to reach the highest, and also to drop to very, very low levels. For those that we have already, we are getting samples every 7 days from them to see, every three days for them to see when they are going to stop shedding the virus, and be able to answer, we're able to answer rightly when we have that data. Briefly, let me just highlight the therapeutics we have. We have the monoclonal antibodies, and in this one, which we're giving Bamlanevumab with Etesevimab. These are monoclonal antibodies which we are infusing. We know that the way they work is similar to the way the vaccines do work. You have they have a neutralizing antibody effect. And these bind to the SARS-CoV-2 spike protein. Remember that protein which you showed, where you have the receptor binding domain, and it blocks the attachment of the virus to the AC2 receptors. That is the way they do work. And when we give them, what we are trying to achieve is we are trying to have these antibodies which we infuse into someone to block where the virus is supposed to attach. And as a result, you have a virus not entering the cells, the host cells, and you reduce disease as well. Data, of course, has shown that they reduce progression to hospitalization and also reduction in mortality as well. Peter?
Okay, thank you, Prof. We'll move on to poll number 3. Let me just launch the poll. Right, okay, so about Bamlanevumab and Etesevimab eligibility. This one is a single choice answer. A, it's effective in people with severe COVID-19 infection. B, it's given as an infusion over 5 days. C, patients with COVID-19 at high risk of progression to, sorry about that, okay, high risk progression are eligible. Then D, has no mortality benefit in patients with COVID-19. I'll read that again. About Bamlanevumab and Etesevimab eligibility. A, it's effective in people with severe COVID-19 infection. Then B, it's given as an infusion over 5 days. C, patients with COVID-19 at high risk of progression are eligible. And then D, has no mortality benefit in patients with COVID-19. So it's a single choice best answer. Okay, some responses coming in. So in the interest of time, we'll end the poll. We've had a significant number of people respond. Okay, so those are the results, Prof, for the poll.
Great. I think, yes, I'll go through and we'll be able to answer this. Now, when we use the monoclonal antibodies, I just need to say it's different from the JAK1 and 2 inhibitors. These ones we have to give in those who have early disease, mild symptoms. They are the ones whom we want to give so that we can prevent progression. Slightly, I think we are divided on this one, but C is the right one. It's those patients who are at high risk of progression to severe disease. They're the ones that we do give. And I'll also call upon Patel and Abraham, who has been doing this work at some point once I discuss this, these few slides. So when you look at the first graph there, it's showing us the risk of time to hospitalization. You can see the blue one are those who are getting the placebo, and that yellow orange is the Bamlanevumab and also the Etesevimab. So when you give the BAM and also you give the 80, you find that you reduce the rate of hospitalization. Again, when you look at the viral load, you see that both BAM and 80 are able to reduce the viral load faster compared to those who are not taking. And that's why we need to give this drug in the early phases. I need to emphasize, though, that there's minimal impact on the alpha and the delta, but the gamma and the beta, they do not work as good as the alpha and also the delta. So fortunately, we can use with our variants which we have circulating. Those who are at risk, we are talking of the older age, those who are obese, the pregnant, those with chronic kidney disease, the diabetics, those who are immunosuppressed, those with cardiovascular disease or lung diseases, sickle cell disease. So we have a number of these parameters which we look at for the people that you need to give the BAM and also 80 combined. We just need to know that these infusions are available, and we have to access them and give those patients so that they do not progress to severe disease. I need to highlight again that those with multiple risk factors, those with obesity, advanced age, immunosuppressed, we need to give them these drugs. But they should have symptoms within 7 days for them to be effective. Remember, the goal is to prevent the virus from binding to the SC2 receptors, and that can only be done in the initial period when the virus is still replicating. We don't, again, give those that have severe disease, those who are on oxygen. You do not need to give them that time when trying to give these, there'll be worse outcomes as well. So it's early disease that you give. What should we look out for? Hypersensitivity reactions, anaphylaxis. You can have infusions-related reactions, and that's why when you're giving, you need to have some AP available with you, so that if someone reacts, you can easily give those. How do we implement? Let me just say that these, we have Bamlanevumab is given as 700 milligrams. Etesevimab is given as 1.4 grams. Etesevimab also comes in 2 bottles. 2 bottles, one is 700 milligrams. So you have to give 2 bottles of Ete, which is 1.4, and 700 of Bam, which is also, you mix them together. Once you mix them in a normal saline, you also have to turn it up, down 10 times. Then you infuse it usually over an hour or so, and you also observe for the reactions. So there are 3 bottles. 1 bottle has Bamlanevumab, then the 2 other bottles have Etesevimab, and you put them in normal saline, and you infuse that. And once you infuse that, you observe for any reactions. Usually, you administer this in a 250 mils of normal saline. I think at this time I would ask Dr. Patel and Abraham to give just some implications and what you're doing when you're giving infusions.
I need to speak up. Sorry.
Hi, good afternoon, everyone. So my name is Dr. Patel. I attend to the COVID outpatients. So far we've had 7 patients that were PCR positive that we have given the monoclonal antibody infusion. So as Professor gave an outline that we give the Bamlanevumab, it's a very complicated name. So I usually just call it as Bam and Ete. So we use 1 vial of the Bam and 2 vials of the Etesevimab. So we've received, as you said, 7 patients, mixed patients, some of them who had underlying conditions. And sorry, my voice projection is louder. We've given these infusions to 7 patients. How we do them is it's just a once-off visit for the infusion. So on day 1, that is when we give the infusion. The infusion lasts about 1 hour or so. We do a calculation rate on the number of drops per minute in the normal saline fluid. What we do is we make a follow-up on the patient on day 8 and day 14 and day 21, every 7 days, to see how the patient is doing. Either we can do a telephonic conversation or the patient comes physically for review. What we've noticed is from the 7 patients, we only had the deterioration of 1 patient whose saturations had dropped. She's currently admitted and is doing very well under the treatment for the COVID-19. So far, that is what I can say about how we are giving this monoclonal antibodies. Just one point to be reminded, these drugs, BAM and Ete, we are giving to only mild and moderate COVID. We are not giving to severe conditions. Okay, thank you.
Thank you, Doc. And just to say that if you are going to give, someone is not vaccinated, you wait for 90 days before you vaccinate, before you give them the vaccination after the infusion. And these guys are doing great work. I'm sure you may have received also, there is a patient due for an infusion tomorrow. What we are planning to say, what we are saying is, colleagues, set up infusion centers in your institutions. and we have these drugs available, they'll be sent over. I don't know, doctor, can you highlight on side effects? Have you seen a lot of side effects with these?
In the 7 patients that we have administered, we have not seen any side effect during and post.
Yeah, how are you?
Findings, hi.
Fine.
Hi, as well.
So in terms of monitoring, again, we have the data registers and we have to leverage on the systems which are available, and you have to report any safety concerns to Zambia. You need clinicians, pharmacists, and nurses to be available. Quickly, let me go to Bursitinib. Now, as opposed to BAM and AT, where we are giving to those with mild symptoms, here we are talking now of another drug which you give in those with severe disease. These are the genus kinase 1 and 2 inhibitors. And remember, what drives most of the pathologies with COVID is the inflammation, the severe systemic inflammation. And we know that there are certain cytokines like IL-6, which drives this inflammation. Now, before you have IL-6, you need to have activation of the genus kinase 1 and 2. And so if you blocked the JAK1 and you blocked the JAK2, then you are essentially also able to block the IL-6. Instead of going, we have drugs which block IL-6. Now we don't have in Zambia that yet, but we have those block the JK1 and 2. And these drugs really, they are doing some good work as well. We have a trial, the COV-BATA trial, which compared the use of the Bursitinib to the placebo. And in terms of the effects, again, the trials did show that those individuals who had been on Bursitinib, the outcomes were really, really better. On Bursitinib, there should be something about 8.1% in terms of mortality compared to about 13% all-cause mortality for those who are on a placebo. And you can see that this reduction is significant. And again, when you combine Bursitinib with remdesivir, the effects are even much, much higher. As I said, before you answer this poll, these ones are tablets. These ones are not infusions. These ones are given to those with severe disease. They are not given to those with early disease. Combining with remdesivir does give better outcomes. Dr. Peter, poll number 4.
Thank you, Prof. I'll go ahead and read poll number 4 as I upload it. So regarding Bursitinib, So regarding Bursitinib, which of the following is true? A, it is recommended for COVID-19 patients on mechanical ventilation. B, it's given as an intravenous infusion over 14 days. C, Bursitinib should be stopped at discharge or at 14 days, whichever comes first. And D, no monitoring is required. So which of the following is true regarding Bursitinib? A, it's recommended for COVID-19 patients on mechanical ventilation. B, it's given as an IV infusion over 14 days. C, Bursitinib should be stopped at discharge or at 14 days, whichever comes first. And then D, no monitoring is required. Okay, so far we have a number of good responses. Majority going for option A. All right, so it's been a considerable number of seconds. I'll end the poll in a few seconds from now. Great, okay, and share the results. So there you are, Prof. Those are the results for the poll. Okay, any comments?
Thank you. Thank you. Maybe I should have not given my statements, like I confused people when I said it has to be given to patients with severe disease. I should have qualified that we don't have data yet on those on mechanical ventilation. Data is uncertain, but at discharge, you need to discharge them from the drug when they're being discharged from the institution or from the facility, or 2 weeks after Bursitinib has been given. So the right answer is C. So let's dive in and just look at the recommendations. So among those who are hospitalized with severe disease, we know that they are having high inflammatory markers, but again, not on invasive mechanical ventilation. So IDSA suggests that you give Bursitinib other than no Bursitinib. So you can see that this is a good indication. And the beauty about this drug, again, it's a tablet. It's given as 4 milligrams daily for 14 days until the time that you discharge. Again, the benefit, it's more in those with severe COVID-19 or those on high flow oxygen or those who are on non-invasive ventilation. But when you have to give mechanical ventilation, really the effect may not be that much. Again, this is from the IDSA guidelines. Again, most of the infectious disease, they like following these guidelines as opposed to the WHO guidelines. So among those who are hospitalized, patients with severe COVID-19 and they cannot receive a steroid, which we use, the IDSA guidelines, they do recommend you give Bursitinib with Remdesivir rather than Remdesivir alone. Now for me, I've been trying to give Bursitinib with even the steroids, with Remdesivir as well. So far, I think we have seen good outcomes for those. And these are people who have had severe disease, and some of them are at risk of progressing to even mechanical ventilation. So far, all the individuals where we have given Bursitinib with Remdesivir, of course, Remdesivir, depending on the duration from the time of symptoms, they have really, really done well. I've become a favorite of this drug, Bursitinib, and I think it's a drug which you can use. Again, we need to know that if someone has a CKD or they have AKI where the EGFR is less than 15, we don't have to give. The absolute lymphocyte count also, they need to be more than 200, and the neutrophil count more than 500 as well. And they should require oxygen. Not receiving dexamethasone or substitute corticosteroids. However, we have not seen any bad outcomes when we have given Bursitinib with the steroids. There are some patients, a few patients have used this dexamethasone, who are very, very sick and also added Bursitinib, and they have really, really done well. And you know, some of these drugs are new, and as you see them, when you treat the patients, you'll be able to get and generate more data and also just to expert use of these drugs. Again, just an emphasis, don't continue after discharge because that time there may be no need. But if someone is still hospitalized, you can go up to day 14. If while on treatment, the person has the lymphocyte counts dropping to less than 200 or the neutrophil count dropping to less than 500, you need to stop this as well. Even those that are creating clearance drops to the EGFR less than 15 as well. And those individuals who are on Bursitinib, they should also receive the Clexan if they're giving Clexan according to the other indications for the use of anticoagulants in these patients. You can get more information from these websites, and Dr. Peter, Dr. Foloshi, I think that has been my last slide. I hand over back to you.
Okay, thank you, Prof, for that wonderful presentation. I think I'll just address one more question, probably regarding the availability of these drugs, BAM and ETE, countrywide. Is it only Lusaka or they are available in other provinces? And if not, can they be accessed? I'll allow Mr. Kampamba Davis to address that question.
Apologies, we are just moving the computer.
Okay.
Thank you so much, Dr. Matibula. And thank you for that question that was asked. So these drugs, Bamlanevumab, Etesevimab, including Bursitinib, are available and sitting at ZAMSA. Now, of course, these are restricted in the sense that it's not like we have hundreds and thousands of these drugs, so a distribution list will definitely be made, and any site that needs to use it can access it. Of course, we'll have to have training, the clinicians and the nurses. As you heard, we have our experts here, Dr. Patel and the rest. So training, prior training has to be made, and then those centers, especially starting with provincial centers, will have to definitely be given these three drugs. They can order through the provincial pharmacies, they can order from ZAMSA, and these drugs will be given based on the distribution list. Thank you so much.
Okay, we hope that was clear. Apologies, we've overshot by 9 minutes. Professor, any last words before we close up?
I think mine is just to thank the people that did connect. Some have dropped out, but really I'm encouraged by just the response and also the questions raised. Let's go out there and emphasize on the vaccination. Let's give the vaccines. We're talking of giving 2 million vaccines before Christmas. That is something that we can do. And whichever vaccine is available, let's try and use that vaccine. Also, as we prepare for the fourth wave, colleagues, let's get these drugs which are available, and let's try and prevent people from having severe disease. But we hope that we can prevent disease from the community, in the community, instead of having the disease available in the sites. That would be a losing battle if we start fighting COVID in the hospitals. Thank you, Dr. Foloshi. And also I need to thank my colleagues who contributed. Dr. Bobo, we are so grateful that you could join me, Dr. Shivemba, and my other two young colleagues, Dr. Patel, Abraham, including Dr. Foloshi and Dr. Matibula. I'm so grateful for your work. Thank you.
Thank you so much, Professor. There's a lot of people in the chat saying thank you so much. So as Dr. Matibula mentioned, we noticed that we packed this session just because we know we haven't done COVID for the Zambian ECHO. What we'll do is that we'll come back and separate the two sessions because there's a lot of questions that have gone unanswered. So thank you all for joining us, and I'm sure we'll have a lot of echoes on COVID, especially in December. Professor and the panelists, thank you very much, and welcome to Dr. Matibula and Esnat. We'll be seeing them very often. We'll see you next Monday, where we'll be discussing hepatitis B. But as Dr. Shivemba mentioned, because COVID-19 is a rapidly evolving situation, we may change that session to COVID-19, but for now, we will have hepatitis B on Monday. Thank you.
Thank you.